Excellent. Wonderful. Well, it's 6 o'clock Central Time. Good evening, everyone, and welcome to tonight's webinar, Understanding PCOS. What is it? Do I have it? Will it harm me? And how do we treat it? My name is Irina MacArthur, and I'm Director of Patient Experience at Inception Fertility. And we are absolutely delighted to have you join us today for this session. Tonight, we are joined by Dr. Eddie Rushev. He is a reproductive endocrinologist at Advanced Fertility Center in Chicago. Dr. Rushev will guide us through the essential questions about PCOS tonight. This session will provide you with practical, evidence-based information to support you in your healthcare situation and decisions. If you have questions to Dr. Rushev, we'll dedicate half an hour to the end of the webinar to answer all your questions. So please submit your question in Q&A box, or if you're interested in asking your question live, you can simply raise your hand and I will unmute you and will allow for questions to be asked. With this being said, Dr. Rushev, the floor is yours.
Thank you, Irina, and I appreciate people dedicating part of their evening to listening to me. We're talking about a very important and very common topic. Next slide. And again, a disclaimer on my end, this represents my particular research, my particular interpretation of the most current scientific data. So it's not really an opinion or a policy by Inception Prelude. So obviously, I would encourage you to talk to your own physician whenever there are any controversial issues that are connected or related to this particular topic. Next slide. And once again, as Irina said, what is PCOS? Will it harm me? That's one of the greater concerns. Do I have it? How do we treat it? Next slide. So, knowing fully well that in this day and age, people have easy access to any information, especially on the web, social media, and otherwise, people that are told that they have PCOS are beginning to worry about the condition, even if they figure it out themselves before the physician told them that they might have it. And then they start reading, as they should. But then again, you get such a barrage of information and people panic because, the baggage that they read about when it comes to PCOS is pretty alarming in terms of life expectancy, in terms of certain diseases, including cancer, diabetes, and otherwise, and people begin to panic. And my job as a clinician, a physician, is to say, whoa, stop. You don't carry all the baggage that you read about. Let's parse it out by asking you about your history, family history, and let's even figure out if you have PCOS. So oftentimes people come to me and say, my doctor said I have PCOS. And I said, okay, do you have regular periods? Yes, no. Have you experienced any evidence of excess hair growth in places that women do not appreciate having hair? Yes, no. Any excess of acne? And has anybody done an ultrasound, looked at your ovaries and say you have the string of pearls, what we call PCOM, Polycystic Ovarian Morphology, fancy term, don't memorize it, but basically the string of pearls basically answer the question, what is it? A ton of follicles, little tiny blisters that are on the periphery of the ovary that looks like a string of pearls. So PCOS is a hormone disorder in women characterized by the presence of at least two of the following three criteria: irregular or infrequent menstrual periods, or even no periods, what we call chronic anovulation or oligoovulation. Number two, some evidence, clinical evidence or lab evidence for excess amount of testosterone. In women, very commonly, it's excess amount of facial hair and hair in parts and on a forearm and otherwise, and also including acne. In the more extreme cases, in male pattern baldness. And those are signs of excess androgen levels, and also it could be lab evidence of elevated testosterone. And polycystic ovaries by ultrasound, and I talked about polycystic ovarian morphology. 2 of the 3 must satisfy the definition of PCOS. If you got only one, you probably don't have PCOS. You have none, you probably don't have PCOS. Next slide. So it's common, very common. If you yourself have PCOS, you're not alone. You're part of the 10 to 13% of the population that has true PCOS. Now, the condition was described first in 1935 by 2 gentlemen, physicians by the name of Steen and Leventhal, but they described a more extreme example. And of course, PCOS can come on different scales. So you may have very mild variation, you may have severe variation. Next slide. So again, the diagnosis typically does not depend on labs. There's nothing wrong with doing labs, but clearly, as I mentioned, if you satisfy 2 of the 3 criteria I just mentioned, then you probably have PCOS. Next slide. So once again, as I mentioned, you don't need sophisticated lab tests. You need an ultrasound and a careful questionnaire. And based on that, most PCOS can be diagnosed. The ultrasound is essential. And vaginal ultrasound typically will see the ovaries close by, and one can tell if you have that morphology with a string of pearls or not. Blood levels of testosterone, if elevated, may be helpful to confirm excess amount of male hormone. AMH, anti-Mullerian hormone, if rather high, can also support the diagnosis of PCOS. However, the AMH by itself is not used to diagnose PCOS. Then there are other tests that one can do to rule out other conditions that cause excess amount of testosterone, including disorders of the adrenal and things that are much less common, congenital adrenal hyperplasia, etc. Blood tests for lipids, blood sugar, hemoglobin A1C, oral glucose tolerance test, or OGTT may be added because people with PCOS are at increased risk of cardiovascular disease and diabetes. Family history is important. If your family history does not have significant history of diabetes, heart attacks, hypertension, strokes, in all likelihood, you having PCOS will you still need extreme close attention by your physician, including your PCP later on in life, and even now, but you may not have that baggage that other people with PCOS may have if they have family history that's positive for the above. Remember also that any assessment of PCOS must include some assessment of psychosocial factors. Quality of life is extremely important to assess presence or absence of depression, anxiety, which are more common in people with PCOS. Next slide. So here's some of the baggage. There's start from the left, increased risk of cardiovascular events, hypertension, strokes, heart attacks later on in life, usually. Increased risk of type 2 diabetes, sleep apnea, increased risk of uterine cancer. There's not increased risk of breast or ovarian cancer with PCOS. Fathers and brothers of people with PCOS may be at increased risk of cardiovascular problems and diabetes, so there's nothing wrong with alerting your family to have themselves checked. Let's not forget there is increased risk of depression, anxiety, body image issues, and eating disorders in people with PCOS. Not all people with PCOS are obese. Many are, which doesn't help their self-esteem. Infertility, of course, is what I deal with the most. And it's very common in people. It's the most common cause in people that have ovulatory issue, PCOS is by far 95% responsible for those ovulatory dysfunction, which is the second most common cause of female infertility. And of course, when you're pregnant with PCOS, especially if you are overweight, those pregnancies are high risk, increased risk of hypertension in pregnancy, gestational diabetes, large babies, difficult deliveries, stillbirths, miscarriages. All those are associated, so it needs to be considered a high-risk pregnancy. Next. So, what should we do? And whether it's we, meaning your reproductive specialist or your primary care physicians, it needs to be a concerted effort. How do you address cardiovascular risk? First of all, you exercise, you diet, you lose weight, you have your hypertension, of course, and blood sugar treated. And the GLP-1, excuse me, receptor agonist, the Ozempics and the otherwise, are a very welcome addition to people who are overweight, obese, and including people with PCOS, especially those that have blood sugar issues. We need to address blood sugar. So once again, it's the same recipe as you saw for cardiovascular risks. How do you address the risk of uterine cancer? We need to scan, we need to typically ultrasounds, we need to, in people especially not undergoing treatment, we need to give them treatments with progesterone, progestin, which is the same family, or even oral contraceptives that will decrease the risk of uterine cancer. Regarding the psychosocial issue, counseling, antidepressants, anti-anxiety medications. How do we address irregular periods? We can give progestin, maybe 10 days each month to cause regular periods, and therefore the lining will shed. We can give birth control pills. We can use metformin that sometimes will regulate the cycles. Spironolactone is an anti-androgen, and that has reasonable effectiveness against hair growth, but you cannot take it in pregnancy. It may cause birth defects. For people in whom it's applicable, especially those with infertility, ovulation medications, primarily oral, but also injectable. And of course, finally, in vitro fertilization for the people who have tried the less invasive procedures and have not been successful, or just outright. How do we deal with excess hair? Local treatment, whether it's shaving, certain creams, treatments by professionals. Birth control pills are quite effective in reducing excess hair, but obviously they're counterproductive when it comes to trying to get pregnant. Next slide. So, as I mentioned, leading cause of treatable infertility. So most women with PCOS, here comes the good news, can achieve successful pregnancies. 95%, as I mentioned, of ovulatory causes of infertility are due to PCOS. Remember, in order to get pregnant, you need a mature egg. If you don't ovulate at all, or if you ovulate sporadically, you're unlikely to get pregnant. So we need a maturation of the eggs that can be achieved by either the oral medications or injectable medications, whether you do in vitro injectable medications or not. So ovulatory issues do not require in vitro fertilization or expensive shots. Sometimes fairly simple medications, fertility pills, can do the trick. And I think that's what you should start with. Next slide. So how do we approach PCOS, especially in our infertility population? Make sure that you evaluate first. Good history and physical, including family history. And of course, what I mentioned to establish the criteria for PCOS, certain labs, but not a whole gamut of labs. Emphasize lifestyle changes before and during treatment. Easier said than done. Many people with PCOS are overweight or obese, have tried throughout their lifetime to lose weight, many unsuccessfully, many successfully and then rebounded. I'm very much biased and in favor of the GLP-1 receptor agonists, the Mounjaros, the Ozempics of the world. And I know to resort to therapy like that may sound like we're bypassing certain things. But in terms of effectiveness, especially when combined with dieting and exercise, it's quite effective. And especially the tirzepatide, less the semaglutide, and you can look it up, but typically Ozempic is semaglutide. The tirzepatides like Mounjaro or Zepbound are more effective in weight loss. I'm not pitching it any drug for any reason except to say this is scientific evidence that people that are on tirzepatide on the average lose 20 to 25% of their body weight, which is significant advantage. Offer the simplest therapies first, and that's advice for physicians. The oral medication that we use are letrozole, also known as Femara, clomiphene, also known as Clomid, and metformin, and offer those first. You can add inseminations to the mix if those medications by themselves do not work, and save IVF as a last resort. Normally in PCOS, I don't recommend the injectables and intercourse or the injectables and IUI because the likelihood of producing multiple mature eggs is fairly high and therefore multiple births. And now you're getting into issues of prematurity and issues that cannot be reversed or must be dealt with difficult decisions. So typically, if we use the injectables, it's with in vitro fertilization. Next. So any ovulation induction in PCOS must consider the risk of ovarian hyperstimulation syndrome, which is a very unpleasant condition that has some dangers. And that is more common in those of you that are not overweight, especially skinny, but have PCOS. So we have to be very careful even when we use oral medications with close monitoring, so we don't get into multiple mature eggs and then multiple births. Metformin can be started to begin with for a few months, and then we can add the letrozole, Femara, or clomiphene, Clomid, to the mix. Interestingly, the GLP-1 receptor agonist, and there is, if you read the package insert, they say don't try to get pregnant if you have had it any later than 2 months. In other words, when you stop, you need to stop at 2 months before you try to get pregnant. That's incorrect. I tell my patients, continue it until you might be pregnant. So typically in mid-cycle, intercourse, insemination, or within the beginning of in vitro fertilization. There's a study from Great Britain that, because it dealt with Ozempic babies, what do you do when people inadvertently get pregnant when they are on those medications, the Ozempics and the Mounjaros and Zepbounds and all that? And the answer is there is no evidence that there are birth defects. So really the advice of not trying to get pregnant anytime before 2 months after the last shot is really a statement from the pharmaceutical companies, what we call CYA, but it's incorrect. Next slide. So let's summarize. What is PCOS? A condition, very common. 10 to 13% of the female population that involves satisfying 2 of 3 criteria. We just went over it, irregular or no periods. Some evidence of excess amount of testosterone, whether it's clinical, excess hair, especially facial, or lab, and ultrasound evidence of polycystic ovarian morphology or string of pearls, 2 of the 3. So really look at to whether or not you really have it, and you can determine it yourself, or at least seek your healthcare providers ultrasounds and all that to see if you truly have it. And here's the problem. Many times I have to tell patients you don't have PCOS. Probably as often as I have to tell them that they do, because somebody out there, one of my colleagues, with all due respect to them, said, you have PCOS, or somebody put the label on them. And once you put that sticker on a person, it's hard to remove. So they look at me like, wait a minute, you said I don't have PCOS, but I've been told all my life that I do. Who to believe? And I say, well, I'm using clinical criteria that are part of what we, the reproductive specialists, use. So whether you believe it or not, it's hard to change the thermostat once people have received that label. Will it harm me? Potentially, yes. And there's more so than just irregular periods and infertility and all that. But later on in life, there are some cardiovascular issues that need to be looked at. And of course, complications in pregnancy. So, and I talked about how we treat it, and it depends on the goal of the person with PCOS. Is the goal to create regular periods? It's different treatment than if the goal is to have a child. So here it is, a very common topic. I hope I at least highlighted some of the important things that I usually converse with my patients about. And maybe it's time to ask questions.
Thank you very much, Dr. Reshef. A lot of very insightful information. I actually will stop sharing my screen so we can have a better view of you. Perfect. Did I stop sharing? Yes, perfect. My slides are gone. All right, so we received quite a few questions already in the chat box. I will read them one by one and will allow you to answer each question. But if anyone interested in asking the question live, please feel free to raise your hand and I'll unmute you. But we will start with the first question. I didn't have a PCOS before, and then I did 3 embryo transfers as a surrogate. First failed, second chemical, third miscarriage. Decided to try for a second of my own and discovered I now have PCOS. Is it possible I got triggered in my body from all the IVF hormones from being a surrogate?
The answer is no. The simple answer is no. PCOS typically is a condition that people are born with. Sometimes people are genetically predisposed. Sometimes you're the only person in your family with PCOS, but you're born with PCOS. It usually expresses itself first during the teen years after menstruation, where people all of a sudden beginning to have those symptoms of irregular periods, which, by the way, are very common to people who start menstruating. So the average age of starting a period is usually 12 in the United States. And a lot of people will have a year or two of irregular periods. So that by itself does not constitute PCOS. But if you have other issues, and most of the hair issues, excess androgen, are beginning to express themselves after you start your periods. So the answer is no, it's not being triggered. And you have to ask yourself, do you really have PCOS, or you were told that you have it? And look at those criteria I just mentioned and look at 2 of the 3.
Thank you. Dr. Reshef, you mentioned irregular cycles in one of your slides. Can you please elaborate? What do you mean by irregular cycle?
Irregular cycles typically refer to no cycles at all, what we call amenorrhea. Irregular cycles are typically people that have less than 12 menstrual cycles a year. So it can be people that have every other month, people that have once or twice a year. Those are irregular cycles. The regularity of cycles, at least in our field, is considered people that have a period every 21 to 35 days, normally once a month.
Okay, thank you very much. The next question is, can you develop PCOS in the late 30s, even if you never had it before?
The answer is usually no, and that refers to the first question. But keep in mind the following. For those of you who have been on birth control pills for many years, whether it's for irregular periods or for contraception, a lot of the symptoms of PCOS may be masked. And when you stop birth control pills, People tell me oftentimes, oh my goodness, I'm beginning to experience unwanted growth of hair on my face, chin, forearm hairs are beginning to darken, and the typical hirsutism symptoms.
Thank you. The next question is, can you have PCOS but not have a strings of pearls in one of your ovaries? If so, do the blisters or pearls develop and then slough off in a single cycle? Meaning, could you have PCOS but just not show any morphology when you happen to have your ultrasounds done?
Yes. I mean, if you have a regular period and excess hair, you have PCOS by definition. You got two of the three, so you don't necessarily need to have an ultrasound. It's nice to have it to kind of look if you have the third criterion. But many of my PCOS patients do not have the classical string of pearls. You know, the original definition by Steen and Leventhal talked about people who were very hirsute, had excess hair, obese, had insulin resistance. Uh, these were the more extreme cases. And then over the years, we realized it's a continuum. So you don't have to have polycystic ovarian morphology or string of pearls to have PCOS.
Thank you. Next question is, I have been noticing more hair growth and acne on my jawline, and one of set lab shows an increased testosterone. I've had ovarian cyst interrupt an IVF retrieval cycle several times, but none of the symptoms have been consistent. They are all sporadic. Sometimes two show up at a time, sometimes three, sometimes one, and sometimes none at all. Do I have PCOS?
Well, PCOS is not a sporadic condition. So sometimes if you've had IVF or ovulation induction, even without IVF, the hormone surges also include testosterone because your ovaries produce testosterone. Your ovaries and adrenals are the two glands that produce testosterone. And there could be a surge of testosterone, and you may feel acne, and even it can be translated into some excess hair. But if it's inconsistent, then it's probably not PCOS unless you've been placed on birth control pills. A lot of the excess hair declines or disappears, and you stop birth control pills, and all of a sudden the symptoms come back. You might have PCOS.
Thank you. Our next question, you touched base on weight loss medication already, but there's a question, what doctor will prescribe me GLP medication during a fertility treatment when this is contradicted by the label? All the doctors are worried about CYA as well. And I'm not sure what CYA is. If you can elaborate maybe as well for other patients, that would be great.
Yeah, and that's a good question. Personally, I don't treat people with GLP-1 receptor agonists, but I do recommend that the primary care physician does. Some OBGYNs, some primary care physicians are comfortable with that. Many of them are actually in this day and age. So, if people are up on the literature and they realize that those statements from the pharmaceutical companies, with all due respect to them, the pharmaceutical companies, are what it is, CYA. There is no evidence that those GLP-1 receptor agonists cause birth defects or anything that's significant. And the other thing is this: the benefit from those medications is huge. Not only in achieving finally some reasonable weight loss, but reducing the risk of cardiovascular disease and diabetes, or treating them when they're present. So typically the primary care physician, whoever that is, whether it's your internist, family practitioner, and some OBGYNs, I mean, again, uh, this is not neurosurgery, okay? It's not that difficult to manage GLP-1 receptor agonists, okay? And most people that treat patients, especially those that treat diabetes, hypertension, and all of that, should be comfortable using those medications. And if you are a patient and your primary care physician is uncomfortable, just gently point out that you heard from some reproductive specialists that their concern about birth defects probably has no basis scientifically. There are studies. You can bring the study from the British Medical Journal to your physician.
Thank you. Um, Staying on the topic of medication, there are several questions actually regarding the medication, but I'll start with the supplements. Are there any over-counter supplements you're recommending adding alongside the fertility treatment?
So what you might be referring to is myo-inositol uh, and others. Consistently, but there's nothing wrong with myo-inositol, but there was just a study that just came out this week that said people that were on myo-inositol during pregnancy with PCOS have no benefit in terms of the complications that can occur from PCOS in pregnancy. High blood pressure in pregnancy, premature delivery, large babies, diabetes, gestational diabetes. Myo-inositol by itself did not provide any benefit. It's not going to do any harm. Clearly, take prenatal vitamins. Uh, Other medications really have not been shown to be effective, meaning supplements. So don't rely just on supplements. That's what I'm trying to say.
Right. And Dr. Ashraf, circling back on GLP-1 medication, is it okay to use this medication while you're waiting for frozen embryo transfer? So
Yes,
before
yes, it is okay. That's what I tell my patients. The only caveat is before retrieval, because, and typically we'll have them stop a week prior because that's a recommendation for our American Society of Anesthesiologists, because the stomach is slower to empty when you're on GLP-1 receptor agonist. So they worry about anesthesia complications. However, more recent data, see, that's a problem in the benefit of reading the literature. Things change over time if you read the literature. So even the American Society of Anesthesiologists now is not as concerned about the using of GLP-1 receptor agonists, even up to the day of retrieval, as long as they know that the patient is taking them, so they can consider it during the anesthesia. But frozen embryo transfer or any embryo transfer typically are not done under any anesthesia. So I would say with some scientific confidence, you can take it, or if you want to be safe, since you usually take it weekly or every other week, drop the last dose before the frozen embryo transfer or any embryo transfer.
Right. Right. As I mentioned, I'll stay on the topic of medication. And the next question is, does berberine act like metformin? What,
Metformin.
I apologize for
Yeah.
mispronouncing it. What is your opinion on it? My doctor recommended it, and in addition to exercise and low carbs, it's been helping
I
to.
don't think it does any harm. It may or may not be as effective as metformin. So yeah, you can try berberine if you don't wish to be on metformin. Remember, metformin can be quite effective in reducing blood sugar, not very effective in reducing weight, by the way, but if you have to take it daily, sometimes several times a day, and it may cause nausea and diarrhea, especially in the beginning of treatment. I'm not sure about berberine because I don't have much experience in using it.
Dr. any advice for patients who is going through this journey with their partner on, how their partner can support them after they've been diagnosed with PCOS?
Wonderful question. And I'm very touched by the question because when you look at PCOS, it has a lot of baggage about, eating issues, body image, and all that, and increase in depression and anxiety and all that. Spousal support or significant other support is extremely important. Remember, Many of you with PCOS have been having weight issues for a lifetime or for a long time. And you've been told, you've been teased, you've been abused verbally because of your body weight, of course, and the role of the significant other, and sometimes mental health specialists, is to mitigate those deeply seated feelings that can really be triggered very quickly when the appropriate support is not provided or when inappropriate comments are made, especially by your loved one. Why don't you lose weight? I've been able to lose weight. Why can't you? Those are things that obviously are very inappropriate and clearly will not help the relationship one iota.
Thank you. Our next question is, I guess I'm one of those women who already been through all those first steps, the less expensive, less invasive attempts, and I've even done 8 IVF retrieval cycles. Many were interrupted because of the cyst-producing hormones. I've had 4 retrievals. We only made 1 fertilized egg that made it to blastocyst, but it has trisom, so it wasn't implanted. Is it possible I've had PCOS this whole time? One of the fertility doctors even caught it. Is there a hope for me yet?
So this is a complicated question because, then if a patient asked me that in the office, I would say, okay, let's look at your cycles. Let's analyze each one of them. Let's see how many eggs you got, how many mature, out of how many potential follicles they got how many eggs. Is that compatible with having PCOS? And of course, you have to have the diagnosis too. But remember that in vitro fertilization is kind of the sum of all things that are good or wrong. And there are a lot of male factor, a lot of egg activation of egg factors, egg quality factors. Your age should play into it, your AMH and all that, the stimulation protocol and all that. So what I'm trying to provide you is how I approach that particular complicated question, because there's no one answer. I'm not telling my patients, because you have PCOS, that's why you're not successful in getting your eggs fertilized. Because if you have PCOS, or if you don't, but you have X amount of eggs and the majority of them are mature, then it's unlikely to be an egg issue. Could it be a sperm issue? Yes, but then you have to look at the semen analysis, and you have to also realize that sometimes your infertility problems come up to light when we do IVF, which is the ultimate way to see if fertilization occurs and if those fertilized eggs becoming blastocysts and mature. And for those of you that have PGT, those are normal euploid. So what I'm trying to provide you is not an answer to your complicated question, because I don't know you well enough, but how I would approach it if you presented it to me in my office.
Thank you, Dr. Rasha. Next question, patient is asking, they have lean PCOS, A1C is normal, and I've been taking metformin, already did my egg retrieval. Should I continue with metformin?
Well, depending on what the metformin was taken for, if the metformin was taken for elevated hemoglobin A1C and you mentioned that it's normal, continue the metformin. If obviously it was given just because you had many follicles, there's no reason to continue it, but it might be helpful when you do your embryo transfer, if later embryo transfer is considered, meaning frozen embryo transfer. So metformin will not harm a pregnancy. And when you look at metformin is not going to make you lose weight. Does it make you feel better? Then take it. Are the side effects overwhelming? Stop taking it.
Thank you. What are your thoughts on, and please correct me if I'm wrong in pronouncing this medication, inositols and or vitamins and teas for adding with PCOS symptoms?
Myo-inositol has some effectiveness. Inositol, myo-inositol, that's basically a similar, those are cousins. Uh, they have no harm and maybe of some benefit in regulating ovarian function, but don't rely just on them as the treatment for PCOS. They don't do any harm and they clearly continue in pregnancy and during your stimulation if you're doing IVF.
Thank you. The next question, I have been diagnosed with PCOS and I'm currently undergoing IVF treatment. Unfortunately, our first egg retrieval resulted in a collection of only one egg and was unsuccessful. What strategies or medications would you recommend to improve the chances of success in the future IVF cycle?
So once again, go back to whether you truly have PCOS, but if you do, um, one is to look at the previous protocol, the stimulation protocol modified. Was that, now I'm getting technical, guys, so forgive me, but you always look at the stimulation protocol and try to do better because for the first IVF cycle, we make certain assumptions. We look at your AMH, we look at your intrafollicular count, how many of those follicles you have to begin with, and then we create a protocol. Most of the times we're right about stimulation, sometimes we're wrong. So change in protocol, whether giving less medication, more medications, using antagonists, using the long Lupron protocol, using a flare protocol. I know I'm getting very technical here. However, really, the physician seeing you must analyze in the previous cycle. For example, if they only got one egg, how many follicles were there? Did they use the right pressure during egg retrieval? Uh, were you triggered at the appropriate time? So maybe next time you can be triggered later. Was the percentage of mature eggs out of the total number of eggs high enough, or they were all immature, in which case clearly there are ways to help maturation, typically more not in vitro maturation, which is not practiced by most practices, but trying a different protocol. So uh, we're getting technical here. I realize that, and I may not give you an answer, but I promise you this, your physician's probably capable of looking at the previous cycle and saying, okay, we made the wrong assumption. Let's try a different protocol. And there's nothing wrong with changing protocols. Different protocols, agonists, antagonists, more medication, less medication, growth hormone, no growth hormone. All those should be discussed with your physician.
Thank you. Our next patient asking, they're 35 years old with PCOS. They have tried letrozole and metformin and underwent through 3 IUI cycles, and they have not been successful yet. Is IVF our next step, and is there anything else we can try before IVF?
Well, my assumption that you've never been pregnant, and if you're 35, consider IVF as your next step. There's nothing wrong with doing more than 3 IUIs. But, it's like you're riding a roller coaster where you feel like you cannot get off of it. And if the physicians say, ride it 3 times to see if it's successful, and then get off of it, breathe, and then, if feasible, do IVF. So I do recommend that you consider at age 35 IVF, including testing your embryos, PGT, but that's not mandatory.
Thank you. Is there any evidence that points towards PCOS contributing to more chemical pregnancies?
Yes, more miscarriages, more biochemical pregnancies, plenty other explanations to biochemical pregnancies. It's usually no explanation because they're very common, guys, even with normal embryos if they've been tested. So realize the following. Only 50% of all pregnancies in human beings will proceed, will become a baby. Only 50%. And generally, and it gets higher as the older you are, 20% of all pregnancies will miscarry. Okay. Sometimes they're lost, many of them are lost even before you realize you're pregnant. Okay, because of either brief implantation, biochemical pregnancies, and otherwise. Oftentimes in real life, we miss biochemical pregnancies, but they're there because we don't test for them. In our infertility world, reproductive world, we test. So that's how we catch those very brief implantations. In vitro fertilization uh, in people with PCOS may be associated with some increased risk of miscarriage and clinical pregnancies and biochemical pregnancies. But remember this, so does obesity. So it's not just PCOS.
Thank you. We still have a lot of questions. So the next question is, I have been on clomiphene for 10 months now, and a few months I did not ovulate, so my dosage was double. Is this normal to be on clomiphene for this long and have no results, or should I try something else?
Well, first of all, in this day and age, in people with true PCOS, clomiphene is no longer the drug of choice. It is letrozole or Femara. The problem with Clomid that's been around since the 60s, whereas letrozole, Femara, has only been around for 25 years, is that if you use it successively, in other words, if you use it month after month after month, it starts having negative effects on your uterine lining and cervical mucus. So it becomes counterproductive. And so I usually tell people if they insist on Clomid or they didn't take very kindly to letrozole, do 3 months of Clomid and then take a break. But not very often do I give more than a total of 6 cycles of whether it's letrozole or clomiphene. However, if you truly have PCOS, your physician should be comfortable, and I hope he or she are, with using letrozole, because letrozole doesn't have the same negative effect on your uterine lining and cervical mucus. Plus, usually clomiphene has more side effects than letrozole. Both have the similar profile of side effects: the headaches, the mood swings, the hot flashes, and sometimes visual abnormalities, but less with letrozole than Clomid. No reason in this day and age to give that many cycles of clomiphene.
Thank you. Can elevated testosterone in mothers during pregnancy affect the hair growth, androgen level, etc. of the baby?
What the question is, I assume, is if you have PCOS, would some of the excess hormone be transmitted to the baby? And normally it's not, because remember, pregnancy is like taking birth control pills. Okay, believe it or not, the placenta produces so much estrogen and progesterone that mitigate the effects of PCOS, and some people may feel some improvement in their symptoms while pregnant, but we don't have concern about masculinizing a female fetus with the mother's excess androgen. The placenta takes care of that.
Excellent. I just saw a raised hand, so if you interested in asking question live, please raise your hand again, and I'll be happy to unmute you. Okay, perfect. Okay.
Yeah, hi. Thanks for the session. So, yeah, I'm the spouse of my wife. So, yeah, we've been trying for a pregnancy. We have done every test, like a low AMH levels and tube tests and everything. And our gynec recently started taking giving a clomid. So we've been taking. She's been taking like a last 3 months, and then still we don't see any luck. So, and she's detected with PCOS as well. So yeah, we are kind of like looking for parents. So yeah, what are our options, and like what's the best way to get pregnant?
Do you have an AMH level?
Yes. What's the AMS level? 6 point something. It's 6 something.
Yeah, which, in the range of what can be considered PCOS. If they haven't tried letrozole yet, it maybe should be tried. How old is your spouse?
She's a 30-year-old.
30. Okay, so you do have some leeway in terms of time, and you don't have to progress to in vitro fertilization. But clearly, in patients of mine that have had cycles, let's say 3 cycles of Clomid, the question I ask them, or I ask myself, have they ovulated on that regimen? Because if they have not, I will either increase the amount of clomiphene, or better yet, I will change them to letrozole. Because, once people start ovulating, theoretically, unless we deal with male factor or tubal factor, they're in par with their next door neighbors that don't have PCOS. Okay. But the count starts when people ovulate, and they need to have at least 3 good ovulatory cycles before people consider other options.
Mm-hmm.
So there's no reason to go to IVF right away in that case, but one can try letrozole if you haven't tried Femara, and even higher doses. And you can try several cycles, but the crucial question is, did the current dose cause her to ovulate? If the answer is yes, continue on the same dose and try at least 3 honest to goodness times, whether it's within a course or with IUI. Added IUI is not a bad option if it has not been attempted yet, if people ovulate, but you have to first ovulate before you add IUI.
Thank you, Dr.
Okay.
Raxa.
Thank you so much. Yeah. So yeah, thank you for explaining. Yeah. So doctor also did that, like, Clomid. Initially, she gave like only 50 mg of Clomid for 2 months, and then 2 months we didn't see any result, or kind of like a pregnancy, and then she increased Clomid to 100 mg last month.
The maximum dose I ever gave of Clomid is 200 milligrams, which means 4 pills a day for 5 days. The maximum amount of letrozole that I use is likewise 4 pills, which translates into 10 milligrams. Remember this, if you ovulate on a certain dose, you're not going to get any benefit by increasing the dose. We sometimes do it, but not really. You're not going to get more eggs. So we try to find the dose that causes people to ovulate and then stick with it. But so the question I have for you is, did your spouse ovulate on the dose of clomiphene?
Yeah. So ovulation kit says ovulating.
Yeah. And the ovulation kit in people with PCOS is a little tricky, because if people have true PCOS and LH is elevated, the ovulation kit measures the LH. Okay. In people with permanently elevated LH, it's very confusing. So doing an ultrasound, even giving a trigger shot while you're on either clomiphene or letrozole, may help in making sure that she ovulated.
Thank you, Dr. Rasha. So we'll move to the next question. What if I had regular periods and after having my first baby, I get my periods every 6 months or so?
You need to be evaluated for your hormones. It doesn't necessarily indicate PCOS. If you had regular periods, it's unlikely that you have or you've had PCOS. If you have irregular periods, one has to look at certain hormones like your prolactin, for example, because it can be elevated and mess up the period. Stress can do it. Several other hormones, thyroid must be tested, of course, because it's one of the more common abnormalities of hormones in women after diabetes. And so in people that tell me my periods have become irregular, I would look for the following: check your thyroid, ask your questions about your health, check your thyroid, assess your stress level, make sure that your hormones are not off, make sure that your AMH is still reasonable, that indicating reasonable ovarian function. That's something we cannot ignore. You're not going to be born and stay with the same egg supply. It declines over time. So one has to always rule out a significant decline in egg supply by doing an ultrasound, looking at follicles, intrafollicles, and also doing AMH level. So it calls for an evaluation.
Thank you. The next question is, can PCOS be a cause of things like joint pain or fatigue?
Fatigue, yes, maybe. Joint pain, unlikely. It's not one of the more common side effects. Remember that fatigue is a very non-specific symptoms. Fatigue can be due to just life's vicissitudes, your workload. Fatigue can be due to stress. Fatigue can be due to measurable physical issues like thyroid, low thyroid more commonly. So, if you have those issues, the joint pain, if that's something new and unexplainable, you need to have evaluation for rheumatoid arthritis, autoimmune disease, lupus, and things like that. Remember that if you're overweight, that by itself can cause joint pain, but if it's kind of a new arrival, it's unlikely to be the weight that is the issue unless somebody has gained a significant amount of weight more recently.
Thank you. Can you please maybe elaborate and explain, the difference between symptoms that caused by PCOS versus premenopause?
Okay, good question. Easily solved, by the way. It requires very little evaluation. Get your AMH. You can even do FSH and LH. So get hormonal testing. Get somebody to do an ultrasound on you. Okay. The menopausal symptoms, especially hot flashes, mood swings, night sweats, and all that, are not just unique to people whose ovaries quit, but they are unique to people who have undergone significant stress, even people with PCOS, people who have had IVF and now they're crashing because they're no longer having that surge of hormones and all that. But a fairly simple evaluation by a reproductive specialist or an OBGYN that's well versed can tell you if you're undergoing menopause or if it's not the case. AMH level being very low, FSH level being high, low number of follicles, they are unfortunately the signs of reduced ovarian function and impending menopause.
Thank you. And we have time for last question. And I know we still have a lot of questions that we're unable to touch base on today, but we will try to get back to each of you with the answer. If you do have your email associated with your name and we're able to reply to directly. If you sign in as an anonymous attendee, unfortunately, I'm not going to be able to track your email address, so you can either resubmit your question with your email address and we'll get back to you, or connect with us maybe next month during another webinar and we'll try to cover some of those questions. So our last questions for tonight is, I have been diagnosed with PCOS over 15 years ago, have high testosterone, facial hair, and have never had regular periods ever. Started IVF last year, had 3 failed embryo transfers so far, was on GLP-1 treatment, but stopped prior to starting IVF at the recommendation of my fertility clinic. My weight rebounded before my next transfer. Would you recommend GLP-1s again to try to get my weight back down? At this point, BMI is about 33 again. While on GLP-1, I lost 30 pounds.
And I don't know how long you've been taking the GLP-1, but I hope I'm not creating the impression that I'm relying on GLP-1 only to reduce weight, because it should be a combination between exercise, dietary, change in lifestyle, and the GLP-1. The answer is yes, go back on GLP-1, especially if you lose weight on it and you feel better in many respects, not only the physical aspects, but also your body image, and of course, just a general feeling of empowerment that you're doing something about an issue that probably has plagued you for a lifetime. And unfortunately, in many cases, GLP-1 is the difference maker. I'd say, unfortunately, we are not aware of any long-term adverse effects of GLP-1. But remember, guys, that GLPs have not been around for more than 5 to 10 years. So we don't have all the evidence. We can never rely just on medications, but there's no shame in taking GLP-1 if your BMI is unacceptable.
Thank you, Dr. Rashef. We covered a lot of very important information today. A question for you: if our patients interested in scheduling appointment with you, and I know you do a lot of telemedicine appointments as well, what is the best way to get hold of you and how to schedule a consultation?
If you download the Prelude Connect app on your phone or on your computer or both, you'll be able to contact my team and they can schedule a virtual. If you live in Canada or far away, would rather not drive to, we have 4 locations in the Chicago area, but this is a big metropolis. And I'm speaking to you now from River North, which is in the middle of the hustle and bustle. But you can schedule an appointment and I'll be happy to discuss it with you either personally and more often virtually. Let me make final statement, which hopefully will kind of leave you with some feeling somewhat better. There are ways to treat PCOS. There are ways to reduce some of the baggage that you'll be saddled with or are saddled with, concerned about your longevity, quality of life, and very important things that beyond infertility. And you need to think beyond infertility because you don't just want to be a parent. You want to be a grandparent. You want to be there in good health for the milestones that your children and grandchildren, and therefore that's why it's important to deal with PCOS. First of all, to make sure the diagnoses are correct, and also address issues beyond infertility. Your blood sugar issues, if you have those lipids, cholesterol, things like that. So it's PCOS is a bigger issue than just reproduction. But many of the problems in reproduction can be treated, and you're not alone. You are part of the 10 to 13% of the females in the reproductive age group. And so if you have a compassionate physician and healthcare provider, then stick with them and remember that you do have a relatively good prognosis in terms of getting pregnant, but you need to think about life beyond children.
Thank you once again, Dr. Rashef. We do those webinars once a month, so please feel free to sign for the next one. And we hope to see you joining us again. Thank you.
Thank you, everybody.